Hello, my name is Suman Srestha. I am a consultant nurse in intensive care at Frimley Health NHS Foundation Trust. In this presentation, I'll be talking about the range of respiratory support that we provide in intensive care, focusing on the ventilator that we use. There are a number of ventilator modes available out there, and it can be extremely confusing if you are new to intensive care. Principles may be similar among some of them, but they are named differently. This is because of the licensing, trademark, and copyright. Different ventilator manufacturers name the modes differently. Please try to familiarize the ones that is used in your intensive care unit that you're working. The range of these modes of ventilators can be simplified by considering these questions. Are the breaths volume or pressure targeted, or both? In volume-controlled ventilation, the tidal volume is set and the airway pressure generated depends upon the compliance and resistance of the respiratory system. Whereas in pressure-controlled ventilation, the ventilator delivers a set inspiratory airway pressure and the tidal volume will depend upon the compliance and resistance of the respiratory system. The second question is, are the breaths initiated by the ventilator or by the patient's efforts, or both? Breaths can be delivered according to a set frequency, which is known as the ventilator or mandatory breaths, or in response to the patient's making an attempt to inhale. Some modes allow a mixture of mandatory and spontaneous breaths. And then the third question to consider is, how is the duration of inspiration controlled? The ventilator can use volume, time, or flow to dictate when the inspiratory phase is complete and when cycling to expiration should occur. In volume cycling, for example, expiration occurs as soon as the set tidal volume is delivered, whereas pressure-controlled breaths are always time cycled. What we mean by that is the inspiratory time is set directly or setting inspiratory to expiratory time ratio. We'll talk about this a little bit more detail a little bit later on in the presentation. Here are some of the most commonly used ventilator modes. Controlled mechanical ventilation, CMV, is a fully controlled mode where the respiratory rate is set and the breaths can be volume or pressure targeted. There is no interaction or synchronization with the patient's efforts, and additional breaths cannot be triggered. CMV is typically used when patients are anesthetized and paralyzed, for example, in operating theatre. The next mode is SIMV, which stands for Synchronized Intermittent Mandatory Ventilation. In this mode, a mandatory frequency of breaths is delivered. This will be synchronized to any spontaneous patient effort of breathing. If the patient breathes between the mandatory breaths or at a rate greater than the set rate, the additional breaths will be allowed. Pressure support is a spontaneous mode where the ventilator provides an inspiratory assist by providing airway pressure as set following each patient effort. In this mode, there is no set rate, and the ventilator will only deliver inspiratory assistance in response to patient's efforts. The next mode is airway pressure release ventilation. In airway pressure release ventilation mode, in short known as Aprv, a high level of Cpap, for example 20 to 30 centimeters water, is maintained for a period of 5 to 6 seconds, with brief episodes when the airway pressure is allowed to fall in order to augment carbon dioxide clearance. It is important that spontaneous breathing is maintained throughout to ensure carbon dioxide control. Airway pressure release ventilation allows the application of a high mean airway pressure to improve lung recruitment and oxygenation. And finally, the Cpap is the most simplest mode of respiratory support for spontaneously breathing patients, where a constant pressure above atmospheric is maintained throughout inspiration and expiration. Here are some of the ventilators that we use at Frimley Park Hospital. Oxylog 3000, this is primarily used for patient transfer. We also have Draeger Carina, which you can use for invasive and non-invasive ventilation, and they're quite portable. We have dedicated non-invasive ventilators. This is the Philips V60 that we use. We also use high flow nasal oxygen system, but primarily we use this system through our main Draeger ventilator, which is the C500. This is our primary ICU mechanical ventilator that is available in all of our ICU bed spaces. This is called the Draeger Infinity C500. This is the screen that you will see when it is switched on. It is essential that the device check and breathing circuit check is carried out before it is connected to a patient. Normally, an ICU nurse will set up the ventilator and perform these checks. However, one of the most important things to remember is to input correct patient height. This automatically calculates the ideal body weight and provides you with mils per kilo tidal volume, which is one of the essential variables when mechanically ventilating patients safely. The ventilation modes of Draeger ventilators can be divided into three ventilation groups: the volume controlled modes, pressure control modes, and spontaneous assisted modes. To indicate to which group a ventilation mode belongs to, the modes are preceded by prefixes in Draeger ventilators. For example, VC for volume controlled, PC for pressure controlled, and SPN for spontaneous modes. There are various ventilator modes that are available to us, as you can see from the screen, but the most commonly used in our units are PC Bipap, spontaneous Cpap and pressure support, and PC Aprv. So once the ventilator is set up and ready to use, select Start Ventilation and confirm your selection by pressing the rotary knob, which lights up after any selection or alterations. Before we discuss the modes of ventilator, I would like to orient you to the main display screen. The screen is divided into four sections. This is the header bar, where you'll see the mode, the battery status, automated tube compensation, size of ET tube, and which setting the ventilator is on, such as adult, child, neonate. This is the therapy bar. These are the ventilator settings that is currently being applied. These can be modified by touching it and using the rotary knob to alter and confirm. This is the monitoring area. You'll see here three graphs: airway pressure, flow, and volume. The numerical values are also displayed on the side. And this is the main menu and bar function keys. This is where you'll find various options to access other functionalities within the ventilator. Pressure control Bipap is the most common mode that we use. Let's discuss some of the settings. The first button is the FiO2, which is used to adjust the oxygen. Then the next to the FiO2 button is the peak inspiratory button. Peak inspiratory pressure is the highest level of pressure applied to the lungs during inhalation. Patients with decreased lung compliance will require high pressures, but shouldn't be applied more than 30 centimeters water without due consideration because of risk of barotrauma such as pneumothorax. There is a built-in safety mechanism in modern ventilators, and it will seek further confirmation before you select peak pressure greater than 30. In the pressure control Bipap mode, the number of mandatory breaths are specified, but the patient can breathe spontaneously at any time. The ventilator provides high pressures as specified on PINS during mandatory breaths, but if patient triggers an spontaneous breathing, then the ventilator delivers pressures as set on pressure support. These pressures are adjusted according to patient's response. Regardless of mode used, the desirable tidal volume should be based on patient's ideal body weight, which is the tidal volume of 6 to 8 mils per kilo of ideal body weight. When using pressure control modes, the inspiratory pressure is adjusted once ventilation is commenced to achieve appropriate tidal volume. The next button is TI. We'll discuss TI in the next slide in a little bit more detail, but this sets the inspiration time. And the next to that now is the respiratory rate. The respiratory rate is set with the aim of maintaining pH within normal limits. Increased respiratory rate allows PaCO2 clearance, but do remember that high respiratory rate allows less time for exhalation and could cause air trapping. It is acceptable to have respiratory rate between 14 to 16 as an initial starting point and adjusted depending on the results of ABGs, oxygen saturation and end-tidal CO2. If there is underlying metabolic acidosis, for example in septic shock or cardiogenic shock, a high respiratory rate should be used to lower PaCO2 and provide some respiratory compensation and minimize the fall in pH. Conversely, in a patient with a metabolic alkalosis secondary to long-standing CO2 retention, the lower respiratory rate will be needed to maintain a normal pH. And the other button is the Peep. It stands for positive end expiratory pressure. It is a mode of therapy used in conjunction with mechanical ventilation. At the end of mechanical or spontaneous exhalation, positive pressure is applied at the ventilator by the ventilator to prevent collapse of alveoli. Peep is used to recruit collapsed alveoli and improve oxygenation, and it should be set at 5 centimeters of water as a minimum. As I mentioned on the previous slide that the number of mandatory breaths are specified, but the patient can breathe spontaneously at any time. In other words, if the patient is not breathing spontaneously at all the mandatory breaths will be delivered at the rate and pressure control that has been set. However, when the patient starts to breathe, they will get the pressure support in the spontaneous periods. In this mode, the mandatory breaths are synchronized with the breathing attempts of patients both for inspiration and expiration. The mode is known as the synchronized intermittent mandatory ventilation, and SIMV for short. Pressure controlled Bipap mode in the Drager ventilator applies this principle. If the patient triggers breath in the SIMV period, the set mandatory breath will be delivered. In the next SIMV period, the ventilator will wait for patient to trigger, but if the patient has not triggered within the first 90% of the breath cycle time, a mandatory breath will be delivered. The other concept that is important to understand when managing mechanical ventilation is the inspiration and expiration ratio. It is often referred to as the IE ratio. A breath can be divided into an inspiratory and expiratory phase. The duration of inspiratory phase is defined by the inspiration time in seconds. Inspiration time in short is known as TI. In other words, the peak inspiratory pressure is maintained for the duration set on TI. So let us assume that the ventilator is giving 10 breaths every minute, a rate we can set. We need then to divide 60 seconds by 10, which gives us a total cycle time of 6 seconds. From this, we can work out how much of that total cycle time is inspiration and how much is expiration. The I ratio of 1 to 2 means that the expiration time is twice the inspiratory phase. In the case of 1 to 2, inspiratory time will be 2 seconds and the expiratory time will be 4 seconds. I ratio is normally set at 1 to 2, but sometimes it is changed to 1 to 1 in order to improve oxygenation by allowing more inspiratory time. This is how the ventilator screen looks like when patient is ventilated on pressure control Bipap. However, when patient starts to trigger the breath, the ventilator recognizes this and provides pressure support breaths. These patient-triggered breaths are displayed as brown color waveform. This indicates the patient is making the respiratory effort. The patient management depends entirely on patient condition when this happens. You may wish to try patient on spontaneous mode if the plan is to wean patient off the ventilator. On the other hand, if the patient may require increased sedation if there is some contraindication to weaning. Now let's look at the spontaneous Cpap mode. In this mode, the patient carries out breathing effort and spontaneous breaths are supported by the mechanical ventilator. In other words, every detected inspiration attempt by a patient triggers the ventilator to provide a pressure-supported breath. Unlike the pressure-controlled Bipap mode, where respiratory rate and inspiratory and expiratory time are sort of determined, the respiratory rate and duration of pressure-supported breaths are totally determined by the patient. To suit the respective lung mechanics, the speed of the pressure increase for pressure support can be adjusted using the slope or flow adjustment to ensure patient comfort. This is the simplest mode of respiratory support, and patients should be in this mode with minimal pressure support prior to extubation. The other mode of ventilation that we use is the airway pressure release ventilation. In short, Aprv. Aprv is used for a certain group of patients, such as a patient with ARDS, pulmonary edema, or also for to recruit lungs as well. During Aprv, a high level of Cpap, for example, about 20 to 30 centimeters of water, is maintained for a period of 5 to 6 seconds, with brief episodes when the airway pressure is allowed to fall in order to facilitate expiration and carbon dioxide clearance. You can see on the graph here, on the peak airway pressure graph, you can see that unlike pressure-controlled Bipap or spontaneous breathing modes, the time spent at maximal inflation is much longer than the time deflated. And this allows the improved lung recruitment and oxygenation. It is important that spontaneous breathing is maintained throughout this mode to ensure carbon dioxide control. This is just to demonstrate the difference between the Aprv and pressure control Bipap. If you look at the airway pressure waveform, the top one, essentially Aprv has a longer time phase on the high pressure level in comparison to pressure controlled Bipap. Because the longer time is spent at the high pressure level, expiratory lung collapse is prevented in Aprv. There are some different terminologies or settings that you need to be familiar when using this mode. P high is the upper pressure that is set, whereas P low is the lowest pressure. P indicating pressure. In Aprv, the patient's spontaneous breathing can take place at the upper pressure level during P high. This pressure level P high is maintained for the duration as set in T high, T indicating times in seconds. So to execute an active expiration and support carbon dioxide elimination, the pressure is reduced for a brief period to 0, which is the pressure low, P low. The duration of P low then is determined by the settings T low. So weaning from Aprv mode is quite different. FiO2 is first weaned down to acceptable range around 0.4 before weaning down the P high. Then we decrease P high in increments of maybe 2 centimeters and start to prolong T-high in increments of 0.5 to 2 seconds. This is done gradually, monitoring patient's oxygenation and work of breathing. Patient will eventually be on a P-high of around 10 with T-high about 20 seconds, which is effectively a Cpap. There are some other important features that I would like to bring to your attention. Oxygen suction button, once activated, will provide patient with 100% oxygen for about 2 minutes. And after that, FiO2 will be back to the setting it was before. It is useful during tracheal suctioning, turning, etc. When you would like to give a patient a boost of oxygen. The major advantage is that the FiO2 will go back to the original setting and not risk the situation where patient stays at high FiO2 if you do it manually. On the top of the header bar, you'll see 3 letters ATC. It stands for Automated Tube Compensation. It's one of the features that we have in our ventilators. The resistance of ET tube or tracheostomy tube can increase the work of breathing on patients. So what does the ATC do is that the ventilator increases airway pressure during inspiration and reduces airway pressure during expiration to offset the estimated pressure gradient across the breathing tube. So ATC effectively removes the imposed work of breathing from ETT or tracheostomy tube when patient's breathing. However, in order for the ventilator to apply correct pressure, we need to make sure that the size of the tube is correctly entered. You can also assess patient's dynamic compliance by changing the screen view here. There are also various special maneuvers functionality available on the Drago ventilators, such as manual inspiration hold, expiration hold. These are quite useful for lung recruitment maneuvers. The physios sometimes use it, and also sometimes you're trying to auscultate heart sounds, and that can be quite useful to do an expiratory hold and listen to patients' heart sounds. So suction maneuver, we've already discussed. This is to give a boost of oxygen therapy for about 2 minutes. Nebulization can be delivered using closed system, and this feature allows the nebulization to occur only during inspiration so that the drug can be administered effectively. Depending upon the volume of the nebulized medicine, the length of time can be selected. There are some built-in safety features on these ventilators. For example, if patient fails to trigger breaths in spontaneous ventilation mode for a certain amount of time, then the ventilator will provide mandatory pressure controlled breaths. The apnea time as default is set around 15 seconds. In other words, if patient fails to breathe for 15 seconds, the backup pressure control mode will be activated to continue with the ventilation. If this happens, the ventilator will alarm and notify you that the apnea ventilation has been activated. And as you can see on the screen, there's a big yellow sign with apnea ventilation displaying on the top. You can also set other alarms such as minute ventilation, peak airway pressure, respiratory rate, and tidal volume. If any of the parameters goes outside the range set here, the ventilator will activate the alarm. The non-invasive ventilation can also be delivered using this ventilator, but it is important to select NIV application mode on the standby page to indicate this. The NIV mode allows some degree of leak compensation and some adjustment on the alarm limits as well. So when NIV is activated, the mode of ventilation is highlighted with orange color. The settings are very similar to spontaneous CPAP mode. When initiating patients on NIV or CPAP, always start with CPAP or low pressure support to allow patient to adjust to the mode of ventilation. High pressure will make them feel like they have just stuck their head out of the window when you're driving at a high speed. This is when the most patients refuse to have NIV because they find it very, very uncomfortable if you start them on a high pressures. We also use our Draeger ventilators to deliver high flow nasal oxygenation, HFNO. Sometimes we refer this as OptiFlow as well, which is one of the trade names. It is a way of giving humidified, warmed, high flow oxygen via nostrils for patients with hypoxemic acute respiratory failure. You can give up to 100% of oxygen at a flow rate of up to 60 liters per minute. HFNO may be valuable in reducing the need for tracheal intubation for those patients who may not tolerate NIV or in the management of post-extubation respiratory failure. So this is the end of the presentation. We'll be providing you with more in-depth training when you're settling in intensive care. But in the meantime, if you have any questions, want to know more information, please feel free to ask all the doctors, nurses and physios in the unit. Starting work in intensive care can be quite daunting, particularly if you haven't done it before. So please feel free to ask any questions if you're not sure. We're all here to help you. So thank you for your attention and all the best.